In this second part, we will do a very simple method of target volume delineation that you can use it in like for your field-based volume when you put the fields, and it's very useful because it helps you to see where is your target in relation to the bony landmarks. Or you can still use it for planning, but you may need some modification, because somebody asked me that when he tried this method, he found that it's not very accurate in terms of the when you draw it step by step and slide by slide, which is clearly the case. But I can reassure you that this method, what we are gonna do now, is so simple, so easy, so quick, and as a starter, you can use it to help you in terms of improving your skills in target volume delineation for breast cancer node levels. So if you if you're now very familiar with what we talked about, like the arch of the subclavian and so on, then you know, or you'll understand what I'm talking about. When you start to delineate, I would start by rearranging them. So don't start by 1, 2, 3, 4. I would start by 4, 3, 2, and 1. And the reason why, because it leads to each other. One by one, we'll move on to give you the second one. So if we talked about the CTL4, if you go to your table now and look at it, where it starts, it will tell you that it will start just above the arch of the subclavian artery. And they want to cover the subclavian artery, and they will tell you something about take one cut or two above, so that it will compensate for what we call it the partial volume effect. We know that with volumetric CT scan imaging, that the what you can see here is a kind of interpolation as well in the slide. So there is something called the partial volume effect, where it can be missed, that you can miss the structure if you don't take a margin around it properly. So don't go for these details, but just go one slide above the subclavian artery, and then subclavian artery arch, by the way, and then you will see that this slide, if you are very familiar with the head and neck anatomy, or you did your head and neck rotation, you can also see my head and neck lecture or brachial plexus lecture, because you will need to familiarize yourself with something just posterior to the clavicle, and this is what we call it the scalene muscles. You will need to familiarize yourself with what we call it the carotid artery, or the internal carotid artery, and the jugular vein as well. So what the guidelines would tell you, that we will not be concerned about the artery, but we just be concerned with the vein, and you just put your medial border of the delineation just around the jugular vein without a margin. When you see, sorry for that, when you see the target volume delineation, it will also tell something about the sternocleidomastoid muscles. In the head and neck, you go just posterior to the sternomastoid muscle, but in breast, we don't usually do that. We just are concerned by the subclavian, by the internal jugular vein. And then there will be a muscles, and just posterior to the muscles, this will be my artery, the artery I'm looking for. So all what you need to do is to take the muscles as well as the artery and cover it properly, and you just end up by something like that. When you go to the space between the clavicle and the transverse process of the spine, or later on there will be the first rib coming in here, then there will be a space that you don't know where to go. There is a muscle called the posterior scalene muscles, and sometimes you can just feel the space and end up by something like that. And I would do it. I mean, it doesn't matter honestly whether you do it like that or you don't take the posterior to the artery, but I would cover the artery properly, especially by working like that without any contrast. If you can see the contrast, it will be very easy for you to delineate the artery and the coverage and to cover it properly. So scalene muscle, internal jugular vein, cover the artery, and that's it. And then go to the caudal edge or the caudal end of this level, CTL4. Now you are looking at the table, okay? So we'll go down, and it will tell you that when you go down CTL4, anatomically, it should end at the clavicular head, isn't it? So we know that at the sternoclavicular joint, usually we put our lower border of the supraclav field just below the sternoclavicular head, isn't it? So if you go to the sternoclavicular head, something like that, and you put and you draw your target like that, just around the vessels that you can see clearly. This is what we call the three branches of the vessels of the arch of the aorta. So this should be the start of the innominate vein. So if you do it like that, you go and just cover the vein, and there will be a dot just beside the vein, and clearly this is the internal mammary artery, as we mentioned in the previous lecture. Now we are familiar with that. This should be honestly the start of the internal mammary chain, but I will leave it there, and I will go one or two cuts up, and I will see how the interpolation will look like. So you can see that the interpolation is a bit generous because of the difference between the first cut and the middle cut and the lower part, the cut, because the lower cut is very small compared to the upper cut, but the interpolation is not too bad. So I'll choose one slice in the middle, something like that, just to make my life much easier, and I will go around the vein again here. You don't have to take the pleura or the vessels clearly, yeah. So I will just end at the clavicular end, or what we call it, the lateral edge of the scalene muscle, and I will just do another cut like that. There is a lot of vessels in this regard, but because we familiarized ourselves before, so I know that this vessel is internal, the subclavian, and this is the common carotid, so I know what I'm looking at, and this is all what I need to do. So one cut above, one cut below, and just interpolate. What are we doing? We are just drawing it in a very simple way. I know that this may not be very accurate, and I will tell you why now. The second step, I want you to go to CTL3, and we talked about CTL3, and I told you before that if you go back to the arch of the aorta, the arch of the subclavian, when the artery will pass between a line joining the so we'll put it like that, just a line joining the clavicle and the first rib. When the artery cross the line between and it's already there from the previous lecture. When you put you see the artery crossing a line between the clavicular head and the first rib, you start what? You start your CTL3. So I will start my CTL3 to cover anterior and posterior to the vessel. And then I don't know where to go. The landmark, the second landmark, we talked about it last time, was this muscle, which is the pectoralis minor muscle. So all what you have to do is to reach the pectoralis muscle, and just at the medial edge of the pectoralis muscle, you just draw a line vertically. And then you will see that you don't have anything to do except to join things together, and that's will be the start of your level 3. We don't usually leave a gap between the levels, so it's either you push your CTL4 to CTL3, or you can push your CTL3 to CTL4. That's absolutely fine. So this is what we call the start of CTL3, which started when the artery crossed a line between the clavicular head and the first rib. Basically, if we will name it from subclavian artery, it's the same artery, by the way, to be the axillary artery now. And then this artery will continue with us with the same story. But I will not do that. I will go down now where the space between the pectoralis major and the chest will become narrow and narrow. So let's go down. You will see that there is a space between the pectoralis minor is here, and this is a pectoralis major is here, and the space between the chest wall and the muscle is getting narrower and narrower, so you can see it like that. So the space here is getting narrower and narrower, and all what I will do is I will choose where the space is about to stop, and I will draw the space again medial to the pectoralis minor and chest wall posteriorly and behind the pectoralis major muscles, and that's it. And then what I will do now is I will interpolate, and after interpolating I will look at it and see, you can see there is some spaces, there is something like may go to the rib a bit, may go up to the muscle a bit, but this is not too bad at all, by the way. And this will be my CTL3. Again, maybe not very accurate, but it's the quickest possible method. Believe me, when I do it in a blink, and that's for me because we usually work on what we call it the field-based supraclav fields. We don't usually contour everybody or planet everybody, so, and I'll show you how to put the field now, but I usually do it like that in a very quick way. And then the second will be, this will lead me to the next step, which is CTL2, and I usually draw CTL2 and interpectoral group as one group because they are basically the same. So usually the interpectoral group is between the pectoralis major, space between pectoralis major and minor muscle. Now we familiarize ourselves with pectoralis minor muscle, so we know exactly where we are. And it says we will start the level 2 will start when the artery cross the medial edge of the pectoralis minor muscle. Sometimes it's difficult to decide, is it this cut or is it this cut? I wouldn't care much, honestly, but I would be generous and I would make sure that the veins are covered properly. So if you think that, okay, so this is the artery I'm following here, and now the artery is coming just above, about to touch the pectoralis minor, that's fine. You can just draw it. If you think that this is too high, you still can go on down. It's very variable. I mean, it's not something like it should be like you have to do it like that, especially without using a proper contrast. It's very difficult. So what we're gonna do now is to draw the space between the pectoralis major and minor muscle and edge to edge of the muscle, so you don't go beyond the lateral edge and you don't go to the level 3. And then you need now to draw level 2, which you go to the posterior edge of the muscle. Okay, so I'm covering the muscle now, but posterior to the muscle there is the vessels which I'm concerned about. Yeah, so you need to cover the vessels as well. You have one of two options, which I usually do, is just join the posterior wall of the chest wall, so just at the level of the chest wall. So take a margin from the vessels as well as in the terms of posterior and ventral. And then this will be the start point of level 2. What should we do? We'll do the same as we did in the last one. I will go down, but where I will go down, I will follow my pectoralis minor muscle along its insertion. When you see the pectoralis muscle going to be inserted into the rib, the space is getting narrower and narrower. And the most important thing I look at that there is no structures in between the muscles. So I'm sure there is nothing between the muscles. Because if there is something between the muscles, this will be the vein that I want to cover it. So I want to go below that, where the muscles are, the space between the pectoralis major and minor are narrower, as well as the pectoralis minor and the chest wall are very narrow. And then here I will draw level 2. How do you draw it? I draw interpectoral group, which is this group, but as I said, I take level 2 with me, which will include the muscles, and posterior to the muscles and edge to edge of the muscle is the medial and lateral border, and that's it. That's it. Yes, that's it. I will do that now. I will do the same, and I will interpolate, and what you will see now is that you will like what I'm talking about. Again, you may see some like kind of a space that you need to maybe push it a bit, but it will never make any difference when it comes for your field-based anatomy now, and I will show it to you. Then the last one will be CTL1. Usually we don't take CTL1 in majority of patients, except in what we call it a sentinel, post-sentinel lymph node biopsy, where the lymph nodes are positive and the patient is not going to go for node dissection, as in the Amarus group. We talked about the Amarus, we talked about the Z11 clinical trial, we talked about the difference between the Amarus and Z11 clinical trial, where the Amarus radiotherapy was planned and the 3-field technique was mandatory, while in the Z11 we said that there was a lot of patients, maybe around 39% of the patients, treated by what we call it a high tange field, and we can talk about it later on. What does it mean, high tange field? So, or some of them also were treated by 3-field technique. But in the Amarus, there was some kind of control of the radiotherapy arm, and there will be clearly the supraclav, medial group supraclav plus the axilla were included in the radiotherapy. So when you go to the level 1, the level 1, they will tell you that the level 1 will start when, again, the artery cross the lateral edge of the pectoralis minor muscle, the lateral edge of the pectoralis minor muscle. Another note in the estro, it says that you have to start level 1 centimeter below the head of the humerus. And this is a bit tricky, I have to say, because it's either that you draw it properly, just going by the vessels. For example, if you see the vessels going medial crossing the lateral edge of the muscle, let's say, by the way, don't forget that the artery is going from medial to the lateral to the axilla, but the vein is going from the arm to the innominate. I know that all of you know that, but just to remind ourselves. So when the artery crosses the lateral edge of, you may tell me, oh, maybe this cut here, maybe it's one cut above, but it's definitely around this area here, because if this is the artery crossing here, this is the artery going there, then when the artery crosses the lateral edge of the muscles, you can draw your level CTL1. You start drawing level CTL1. And level CTL1 is also so easy, because the medial border will be the level 2, as we can see. And then you will extend. You see that there is a pectoralis major muscle here. So go to the lateral edge of the muscle, this like that, something like that. But then you don't know where to go. I was just talking to you about what we call it the digging into a space between the teres major and latissimus dorsi. We don't do that. I said we will just be at the edge, that's what they call it in the guidelines, imaginary line. So don't take the thoracodorsal vessels. You just get imaginary line just touching the vessels, or keep it in the posterior to your line. And then another imaginary line joining the most biggest or the biggest muscles seen in this field, which is latissimus dorsi and pectoralis major. So I would do it something like that. Maybe it's not, again, very accurate, but I will leave it like that. And then I will go again down this time to where? To rib number 4. And that's why I wanted you to familiarize yourself with rib number 4. And I said that you can easily count it by, in the coronal view, 1, 2, 3, 4, and then you put a mark at level 4. So level 4, or the rib number 4, is not only for the internal mammary vessels at the sternum, but it's also the caudal edge or the caudal border of the axillary lymph node, CTL1. So with CTL1 axillary node, they said you go down to level rib number 4, or sometimes rib number 5, based on where was your lymph nodes located. If you have like a very low lying lymph node, maybe you can go to 5. If you have higher up, you can go to 4, and that would be fine. And again, you will follow the same principle. What is the same principle? I want to be lateral to the pectoralis minor muscles, yes, and I will be lateral to anterior to, sorry, let's not allow me to use a brush, anterior to thoracodorsal vessels, which I will not take it, yeah. And then you'd have nothing except that you have to go to the chest wall. No, there's nothing else to do. And then you join the line. Sorry, it is not very nice. So let's do it like that. And then join a line from the pectoralis major to latissimus dorsi muscle edge, imaginary line. Let's say that you see like some soft tissue changes, or sorry, some fibrosis here or there. I would take it. So I usually make it a bit wider. If you take, sometimes you see a seroma, I usually take it as well, but it's up to you. But I would consider seroma as a high risk, and I sometimes take it. But usually we do the CTL1 only, or majority of the patient, because rarely I have to say that, I mean, following the axillary dissection, you wouldn't expect a recurrence to be above maybe 2% in good axillary dissection surgery. So we don't usually do CTL1 in the majority of our patients, but we do it when there is no axillary dissection. There'll be like some sentinel lymph node 1 based on the amarus. We can treat the axil, and that's it. And I will just interpolate. Do you think that this is enough, Dr. Haddad? I would say, for me, I will tell you that this is enough. If you look at it on the coronal view, it looks beautiful, yeah. I have to admit it's not very accurate when you look at it in the axial view clearly, because this is a very quick method. I'm not here to give you the guidelines. I'm not here to read the guidelines for you. You can read it yourself. I'm giving you a very simple and quick method to start with your career in a breast rotation. But still, saying that this is not too bad, I will tell you how. For example, if I want to be more accurate with CTL4, what you have to do, because now you know it is in place, and I'm telling you, don't leave a margin around the vein. All what you have to do is to just trim things from the normal tissue. So for example, if this is a cut seeing around away from the vein, all what you have to do is to trim, and so on. You go to trim up, and also if there is inside the lung, you trim from the lung, and so on. This is very easy to do, and you can do that, by the way, but I will not do it because I don't have time. I usually draw these kinds of this drawing for me in the field-based things. So I want to do something quick to know exactly where I'm putting my field. This is number one. And number two, for plan acceptance, when you say, for example, I want to give a direct field prescription, you know exactly how, you have a feeling about how deep is your volume, you know. This will give you an idea about how deep is your volume. Also for the physics team, when you put a structure there for them or a target for them, they will see, oh, it's not very well covered. Would you like me to use a 10 MV, Dr. Haddad? I would say, yes, use it. Or I would say, no, that's fine. If you see that the coverage is with 80, 82, 85%, I'm happy with that. And we don't usually should change it. But let's have a feel now and look how this drawing or quick way of drawing things will help you to put your field properly. Let's say the radiographer, they gave me the fields like that, because most of us are working on a field-based radiotherapy, and we don't usually draw a single cut by cut. You look at my drawing. It's beautiful because it gives me an idea about where my field should be located. Basically, we usually use a supraclav with what we call it a half beam block. So this is my first step. I will change the Y1 to 0, and for my junior colleagues, please, when somebody will ask you about what does it mean half beam block, you have to have a definition in your mind. And basically the definition of half beam block, again, this is for example minus 10, this was like that. The definition of half beam block is to use the most straight part of the beam as a border. The most straight part of the beam as a border. What is the most straight part of the beam in our radiotherapy? The most straight part of the beam is the isocenter. So basically, we are using the isocenter to be a border, non-divergent border. So you end up by having what we call it a half beam block by just closing one of the jaws to 0. And this is one of the drawback of the half beam block. It will make you be limited in terms of how long the field would be. For example, if you're putting a breast field and the breast field you cannot extend your breast field beyond the maximum of 19 or 20, because the maximum field, we know it's 40, so if we use half beam block, it will be only 20. So if you have a bigger chest wall or a big lady where you want to use more than 20, it will be limited. You cannot use it for half beam block. But half beam block for supraclav is very, very, very nice, and we use it quite often. And then the second, so if the first step we did is we closed the jaw to use a half beam block, and then you need some anatomical landmark. Let's close my volumes and use the anatomical landmarks first. So we all know that for the anatomical landmarks for the supraclav field, we use the medial border to be at the lateral border of the vertebral body. In another word, it will be the medial border of the internal jugular vein. So because we used to put our medial border on the lateral edge, this is X1. So X1 will be, now we close it, to use it, to put it at what we call it the lateral edge of the vertebral body. Because we are doing this in a kind of a routine thing. By the way, some would use what we call it the crust or supraclav crust, and it's a bit weird. We don't usually do that, but some of the clinical trial did that before, so it's not our time to save time here to do it. But anyway, so the lateral edge, the medial border of the supraclav field will be the lateral border of the vertebral body, and we all know about what we call it a gantry angle, that you usually move the gantry angle a bit of 5 degrees. But this you can do it later on. I will tell you when and why. And this is the case. So the medial border, if the supraclav field, usually it's a lateral edge off chord. It's usually off chord, and it is at the lateral edge of the vertebral body. And then the lateral border of the field, you have two ways of doing things. One way is that we want the axilla, which is why I'm giving you this lecture, is to familiarize yourself with the field in the amarus, where you want to take the axilla. If you want to take the level 1, which is the axilla CTL1 in your field, all what you have to do is to put this border, to put the lateral border of supraclavicular 1 centimeter from the head of the humerus. So you can see this is the head of the humerus clearly, and then you just move it outside the head of the humerus by around 1 centimeter, and we can do it now. By the way, I'll tell you now that it's not necessary to be 1 centimeter, but this is, for example, 60. I will move it to be 65, or maybe if you want to do it 70. The good thing about this now, that if I open my CTL1, I can now see that, okay, there is this is covered or not covered. So because I drew it already, I can easily open my my field around it if I want. For example, if this is my CTV, so I need to take maybe half a centimeter PTV and then half a centimeter for the penumbra, something like that. But this is how helpful my target would be. You'll tell me that we don't irradiate the humerus. Yes, I will put a shield on humeral head, and that's who the Esther was talking about. The Esther was talking about the fact that when we used to put a shield on the humerus, this means that the upper part of CTL1 will be compromised. Yes, it's true. And we don't usually care about the most upper cuts of CTL1 because we don't usually see recurrences in there. So feel free to shield the humerus properly, and tell your physics or dosimetrist that you know that the upper cuts of CTL1 will be compromised in the dose coverage, and that's absolutely fine. And then the upper border, which is here Y2, and you have different ways of doing Y2. Sorry, before going to the upper border, I want you to familiarize yourself also with what we call it the small supraclav field without taking CTL1. You just need CTL2, where your border will be, and again here will come the cricoid, coracoid process, the coracoid process. I don't know if I said cricoid in the previous lecture, so please forgive me if this would be the case. So the coracoid process, you can see it here, you can see its projection, which is basically when some of the books would say it's medial to the head of the humerus. So some of the books you read that the lateral border of the supraclav field should be placed medial or 1 centimeter medial to the head of the humerus, something like that, or is lateral to the coracoid process, which is, as we talked about it, in relation to the pectoralis minor muscle. So this would be your field, or if you don't want to take level 2. Sometimes, which is very good for me, and I like that so much, when I open this, let's say I want to take level 2 properly because my surgeon didn't touch it, for example. So if I put my level 2 here, you can see it's cut. So this is, I will leave it for you, meaning that if you think that your surgeon didn't touch level 2, which sometimes is the case, and you want to cover level 2 properly, which is here will be the blue color, then all what you have to do is to push your lateral border more. And this is why it's very nice to draw your target. That's what I'm talking about. What is the value of drawing my target if I'm going to use it as field-based? Then you can do it like that and then shield your humerus. I'm not intentionally taking level 1 at all, and maybe taking part of level 1 in the field, but my concern is about level 2 that the surgeon didn't touch it. So by just drawing it quickly in few minutes, I can now place my border and know exactly where is my target, and this is also very useful to use. I personally like it because give me a confidence of that patients treated with field-based are not like compromised in terms of the coverage of what I want to cover compared to another patient who will have like a VMAT or be treated with full target volume delineation only, and you expand it with a PTV. So by doing this, I feel like more satisfied, I have to say. The last border would be the Y2. The Y2, you have one of two ways of doing things. It's either that you work estro based, yes, which is talking about that the CTV will be the upper border of the subclavian artery, yes. So this is what we did, because I draw this upper border here of the CTL4 based on my anatomy and vascular relation, which is the arch of the vessel, yes. So this is CTV, and then clearly, because this is a CTV, is not a PTV, then you need another maybe half centimeter as a PTV, yeah, and then maybe another half centimeter for the penumbra. So you end up by a field like that. The other ways of doing things is that you work on the RTUG based, which is talking about that the upper border should be at the cricoid cartilage. So the CTV for the RTUG is at the cricoid cartilage. In this case, if you want to cover this region properly, you mean the cricoid cartilage level properly, then you will need to go higher up, clearly. So you may need to open your target more than that, and then you end up by covering your cricoid cartilage region. And that's why you will see that in some centers the upper border is different. There is nothing to do with the clavicle, because I had this question before. We are not covering the clavicle. We are not covering the clavicle. We are covering lymph nodes on the neck. And this is what we want to do. So if you want to cover the area of the cricoid cartilage, then you need to go higher up more than that. So you may reach the larynx by a border, but the dose will fade away at the level of the larynx. It will be mainly the cricoid cartilage. Knowing that, don't forget that we have some data to say that thyroid function can be compromised in some of the breast cancer patients. Some female patients, even by taking small part of the lobe of the thyroid in the field, not both lobes, they still suffered from hypothyroidism. And there is data, you can refer to it a lot. The lower border is usually at the sternoclavicular joint, or the lower border of the sternoclavicular joint, just below the head of the clavicle. Seeing again that I drew it like that, I can push it up if I want. It's not a problem at all. For example, I don't think I need to go that low. I can push it up. Just you need to leave, as I said before. So this is a CTV, so you need a half centimeter PTV and then half centimeter for the penumbra. So you may save it like 1 centimeter below your target to get good coverage. This is why what I'm saying about why I would like you to draw all patients, all breast patients, because this will give you confidence that you are treating your patient in a very nice way, whether field-based or whether it's not field-based. If you want to make the shield here, it's very easy. We have tool to, so if you want to shield the humerus, if you just draw your shields, and it will be so easy. Something like that, and you shield. You can see that you will see that your uppercuts are a bit compromised. But I wouldn't care much, because we don't usually see such recurrences, and you end up by a field like like something like that. Or if you will take the axilla level CTL1, then you just push this border more laterally, and then you shield your humerus completely. And this is how you do your supraclav field. The nice thing about this drawing as well, that you can easily see that you are covering the vessels. Can you see, if you look at the sagittal view and just remove everything, you can see here the vessels are very clear in relation to each other, subclavian artery and vein. And if I open my structure now, and I can see that I'm covering my vessels with a margin. For example, if I'm not too generous, then maybe you can take more cuts. If you think you are too generous, more than ½ centimeter or a lot, then you still can remove 2 cuts. But I can see here that my coverage are beautiful, and I'm covering the subclavian, I'm covering the internal jugular, I'm covering the vessel. So after completing my target volume, I would look at it on the sagittal view and make sure that everything looks nice and very well presented. So this is a very simple method for drawing your target. Believe me, when you do it, it may not take more than few minutes, and you will be surprised on how quick you can do this. And you will be also surprised that by the time you will start to when you go with your for example, after drawing all this, and you look at it and get your table for the target volume delineation, you'll start to familiarize yourself more and more, and you'll start to see, oh, that I need to push this a bit more. For example, here you shouldn't leave a space there, I should be medial to the vessels, I shouldn't take extra space, and so on. So as if this is a start for you to familiarize yourself with all target volume delineation guidelines, whether the ProCab, whether the RTOG, or whether the Estro guidance. But I hope this is a useful lecture, and this is what I gave it in Arabic. There is one last thing I forgot maybe about what is the gantry angle. So look at my CTL4. For example, if I want to cover this CTL4 completely, so although this is, I said we can trim it, but let's say I wanted to cover it properly, I want a margin from this, although we don't, by the way, but I'm just saying that because it's not routinely that we do a 5-degree gantry angle, but the gantry angle will give you a space here. So you can see it here. Will give you a space, and it will allow you covering. The gantry should be in the opposite direction. Sorry, it should be away from the spinal cord. Don't forget that. I'm sorry. So it should be away from the spinal cord. So if you do it like that, and you feel like it's narrow. 5-degree. What we can see here, that we see there is a space now between the vertebral body and the beam. So I still can open. What is this? This is X1. So I still can open X1 if I want to cover. Let's remove first this block, just for us to I think to just get rid of it, and then go to the simulation. So you can open X1 because you're still away from, so you can see you're still away from the spinal cord. Yeah, so you can see it here in the axial view. So now you are covering CTL1 properly while you're not touching the spinal cord. And this is the idea about what does it mean angulation away from the spinal cord. If this is be 0, and then there will be 5. So this is the gantry angulation that I forgot to say. Thank you very much for your attention. I hope you will find it useful. Please, if you have any question, put it in the comment or send me an email. And I hope that you will start your breast rotation with a very strong start. Thank you.